Okay, this is Dr. Doherty. I hope that you all can hear and see me. We've had some technical issues here with the webinar. I think we all know that we've had to switch over to lots of technology that we haven't used that much previously. So please bear with us a little bit here. I'm the hospital epidemiologist at Baptist Lexington and an infectious disease specialist. My partner, Dr. Rodrigue, has given 3 of these updates previously. This is a sort of a comprehensive update and review of the COVID-19 outbreak. There's several issues that we're going to try to address today that are relatively new issues. After Dr. Rodriguez speaks, Dr. John Barton will be talking about OB issues related to COVID-19. He just helped write the national guidelines, which should be published in the next couple of days, so this is hot off the press. The other issues that we're going to try to address today is how do we open back up the hospitals for elective surgery? How do we open up the economy, and what's the path out of this? So Dr. Rodrigue will be speaking right now. Thank you.
Okay, first I'd like to say that my pants are a current a casualty of COVID. I just noticed I put them on and went off to work, and my wife is a little bit more paranoid than I am about COVID, so she put a ton of bleach, and I've got spots all over my pants that are all bleached out. So these are the last time you'll see me wearing these. Let's move forward. The pessimist sees difficulty in every opportunity, and the optimist sees opportunity in every difficulty. And clearly we're at new frontiers in terms of how we're handling a new disease, a new way of cooperation between different entities that never cooperated before and didn't really have much of a relationship before, whether it's the nursing home and the hospital and the public health department and different hospital systems having to do new things with new technology like WebEx or whatever the technology might be, and the glitches that entails. So we have to continue to develop our tools in order to move forward with this outbreak. These are slides that will be available on the Baptist system. You don't need to copy these down. I'm not going to spend a lot of time on each slide. Some of them are somewhat redundant, but to try to set them up to give you a certain flow of what we're dealing with. The outbreak began by our recorded understanding in December in China, and by March, WHO declared this a state of emergency. The story began in terms of unknown, unusual pneumonia cases in Wuhan, and then tracking that down to a live market, a wet market, and then subsequently spread across the world, as evidenced by this map with from WHO in terms of number of cases. Essentially, it is a worldwide epidemic involving the majority of the countries, with a difference in terms of not everything is happening at the same time. You have the beginning of the outbreak in China, spreading it to Europe, and then America following after that, and then different countries as they develop more capacity in terms of testing and finding out that they have the disease as well. The numbers will change as time goes on. So cases globally are over 1.7 million to date, with over 100,000 deaths. And Europe's still a hotspot with over almost 1 million cases in and of itself. The case fatality rate will differ depending upon what case series you see, but it still holds at about 2%, with the highest risk factors being age, comorbidities, and with a 5-day incubation period. The bat it tends to be the origin of this new coronavirus, with potentially an intermediate host identified as the pangolin. Epidemiology in terms of the transmission routes have not changed. We're getting new information over time, and this is typically what happens. So you start with an outbreak, you have to look and continue to look, and then document how you think the routes of transmission are. So it still holds true that droplet and contact are the primary modes of transmission, although as we continue in the outbreak, we learn that aerosol transmission is still a possibility. There still is no great evidence for vertical transmission in pregnancy. SARS is found in numerous specimens, probably the best specimen being the endotracheal specimen from bronchoscopy. Whether or not you can isolate it at the same accuracy from a saliva, because there's literature out there saying saliva is a great potential. It's difficult to compare different studies. They're all done with different levels of rigor. And so I can't say that, it's still right now nasopharyngeal probably higher than oral and saliva testing, but I think more data will come out, and maybe saliva testing, which is certainly more palatable and more easy to do on patients, will become a standard. We know that SARS can be found on all fomites, so the more we go along with this illness and disease, the more we can, and look at the settings that we're treating it, the more we find it on houses of patients that have had SARS, or hospital units looking at all the different types of high-touch surfaces and finding that they can persist on those surfaces. And then you have laboratories doing, trying to reproduce what might happen in real life, and that's where you get some of that literature saying, for example, that it can persist on the cardboard surface for 24 hours, but potentially on a copper surface longer. This isn't a unkillable virus. It is an envelope virus. It can be killed with soap and water and with dilute bleach solutions and alcohol solutions that have 60 to 70%. There are some more aerosol literature now coming out. If you look at the literature, however, it's not all, again, the same quality. So in a field hospital, they were able to find virus isolated from toilet facilities, anterooms. But the important point also to drag away from that article was that cleaning has an impact, which seems intuitive, but it's also comforting to know that if you step up your infection control policies in terms of environmental cleaning, that you do have an effect. There was one article written from MIT talking about turbulent gas clouds and the fact that you, with a very forceful cough or sneeze, could potentially detect the virus up to 27 feet away. There was some controversy about whether that was accurate in terms of what people would normally do in life. There always has been a controversy in terms of respiratory and aerosol transmission when you talk about respiratory viruses. So that isn't an unusual thing. If you go back to the literature, there are review articles discussing people's terminology and whether or not one method is more important than another. Clearly, this respiratory virus can be transmitted primarily by droplet, but also by aerosol, with a special focus on those procedures that generate aerosols. And we touch on that a little later. If you look at, again, samples from the ICU, important, these are kind of representative potentially of how we are in our own hospitals. If you look at COVID units in China, over the past couple of weeks, they sampled different areas within those COVID units and found a significant amount of viral, at least RNA, on floors. Up to 70% of the floors were infected. Computer mouse, 75%, trash cans, handrails, patient masks, also air outlet filters. Air near the patient tended to be up to 44% they could detect, but air near farther away in terms of distance, a lot less so. Soles of medical staff, up to 50% of them working in and out of COVID units were able to detect PCR. So the takeaway message from this, I think, is if we get extremely busy and you have a unit full of very critically ill patients, you have to assume that your environment is more likely to be infected going in and out of those rooms. Whether or not you have to put a shoe cover on every time in and out, probably not, but you do have to pay attention to increased environmental cleaning and the fact that you can track this virus into different areas. Contamination was greater in the ICU than it was in the general ward. Again, probably reflecting the amount of symptoms that those patients have, potentially the amount of viral load as well. This is a representation of how they looked at and where they sampled those the virus in terms of the patient's bed, right at the patient's level, behind the bed, right behind where the air outlet would be, and in different areas of the unit, again, where the beds were located in the ICU, a much higher rate of positivity than the general area where you would be doing your notes. If you looked at the exposure rate in healthcare workers who were exposed to a patient who was not known yet to be COVID positive, but did have an aerosol procedure, but they were wearing PPE. This is one study that was comforting in terms of out of the Annals of Internal Medicine, showing that they could not detect any of those healthcare workers becoming positive. So PPE has some protective effect. Asymptomatic transmission has been more and more information on that. I went over that last time, but this was a new slide out of the MMWR from the nursing home outbreak, showing that over 50% of those patients, including those that tested positive, were asymptomatic. Now, remember that at one point in time they were asymptomatic. If you follow a percentage of asymptomatic patients, a percentage of those people will subsequently develop infection. But if you used the criteria of having to have symptoms and screening those patients in nursing homes, you would have missed a majority of cases. And we're taking that information now and using that toward how we're looking at our own nursing homes, say in the state of Kentucky. We do have that as a focus of magnification of these outbreaks. If we just have one patient and assume that it's that only patient because nobody else is symptomatic, we're going to miss a substantial number of either healthcare workers or residents of those nursing homes that are truly positive and would amplify those outbreaks and then again fill up our hospitals. The story of high viral loads with asymptomatic cases or pre-symptomatic is again dramatically demonstrated by looking at the cycle thresholds, which the lower the cycle threshold, the higher the viral load. And whether you're asymptomatic or symptomatic, you tended to have fairly high viral loads. So it increases the risk for your ability to be able to transmit that infection. That again was shown in an outbreak looking at 18 patients in Wuhan, where they were looked at viral load and they looked at asymptomatic status, and they detected even if you were asymptomatic, you could have a relatively high viral load. Now, when you talk about asymptomatic, this kind of popped into the radar, and that was the safety of blood. So the safety of blood at this point is relatively good. However, when you actually go backwards and look at blood safety with screening of patients that were asymptomatic, they actually are able to detect virus in that blood. So that it makes us think twice again about, we can't use, blood centers usually use a symptom form, making sure you're not sick when you're donating. But in fact, when you're in the middle of a big outbreak, you can have patients that were asymptomatic and donating. So here's 4 patients that they were able to detect by going backwards in China and testing that blood at the blood center. Super spreading events are still important. We can see that all around us in terms of what happened at Mardi Gras in New Orleans, church events, California. Singapore is reporting that when they started to relax some of their restrictions, they start to see flare-ups of illness. Pilgrimages to religious sites. On the right-hand side, you see the map, which is some religious sites in Iran. And you have people from Pakistan going to Iran for these religious pilgrimages and then coming back to Pakistan and carrying the illness with them. And of course, the transportation story in China, where you had 5 million people leaving a large spring festival celebration and spreading it to the rest of China. That story is illustrated in this slide, which I call planes, trains, and automobiles, where it's not an uncommon feature that some of the mechanics of transmission depend on what goes on in your area. This is a point map showing you active cases of cruise ships along the world, where cases were being spread via cruise ship industry. And if you look at Chicago, small events like family get-togethers and funerals, they were able to track before the institution of restrictions, outbreaks of cases and deaths tracked to something as simple as a get-together for a funeral. This has led to some of the recommendations for restriction of these types of activities. Healthcare workers are still an evolving story. It's a little bit frustrating for those of us that are trying to fashion policy to not always have the data in terms of the percentage of healthcare workers involved. But clearly it has evolved from a low of 3.8% reported in the Chinese data to 20 to 29% as we go along. And within our own state, knowing that we have a significant percentage of healthcare workers also getting infected. Most of those people getting infected not having a lot of symptoms. That nursing home outbreak in Seattle also illustrates how you had residents getting infected, healthcare workers getting infected, and this story again is repeated again and again. So even in our own state of Kentucky, we have had significant numbers of people working within nursing homes become infected and those residents becoming infected. So as we gain more of an awareness, we strategize about case containment really at the public health level, where they are swooping in trying to test the people in the nursing homes and the healthcare workers in the nursing homes and trying to control that situation. So while on a community level, we're not doing massive case containment because we basically have a lot of community transmission, it's hard, we don't have enough people to do that. It's reasonable focusing on some high risk areas to use this type of data and say we have to swoop in and try to stop it before it becomes a fire. United States epidemiology, we know that we're having increases in cases, over 500,000 cases, 21,000 deaths. The first death in the United States in January. And as time goes on, the outbreak continues. New York with an amazing 188,000 cases, and then it really drops off as you go along. This is not a simultaneous outbreak. Obviously, every state has a slightly different timeline of when they instituted mitigation strategies, social distancing, the messaging, the stopping of elective procedures, the stopping of funerals, schools, et cetera, probably can correlate some of that with the case development in each state. And also our states are not completely similar in terms of population density. US, in terms of respiratory specimens, you can look at covid.net, which is a surveillance system in 99 counties. That's on CDC's website, based in 14 states. 18% of all respiratory specimens are testing positive at this point, 7% or so at clinical labs, a higher percentage at commercial labs. Hospitalization rates continue to go up, 12 per 100,000, but notice that it goes up as high as 39 per 100,000 for those that are 65 and older. Amongst the people that were hospitalized, 90% or more have had chronic conditions, including hypertension, obesity, chronic lung disease, and diabetes. So chronic comorbidities certainly play a role in terms of your likelihood of being admitted to a hospital. There's been discussion about male gender with increased mortality, maybe related to the presence of chronic comorbidities. A similar increase in mortality noted amongst African Americans compared to their population, and may be related to no firm data on this, but may be related to comorbidities as well as difference in terms of access to care, prevailing attitudes, which is under the rubric of health literacy, and also population density. Vulnerable groups for poor outcomes, it's still, besides the usual risk factors for with the comorbidities in terms of diabetes, COPD, et cetera, other aspects have been impacted by this outbreak, including the homeless, the underhoused, socioeconomic factors. So the less money that you have, the more you're going to struggle financially, mentally, physically, dealing with this outbreak. The response to COVID may also impact treating other illnesses. This is not an uncommon thing when you talked about Ebola in the Democratic Republic of Congo. So they're focusing on Ebola, but then they have a resurgence of measles because there's kind of a diversion of resources and a change in focus. there are articles reported in terms of looking at the increase, for example, in coronary artery disease outcomes based on our difficulty dealing with a significant outbreak. I'll kind of skip through this, but you can see the outbreak curve. In January, we had that first case back in Washington, and we're still continuing to increase. Kentucky probably not as bad off as some other states, especially on the coasts. Significant message here being that everybody gets affected in terms of hospitalizations, although we focus on the mortality rate with being older. You can still be 20 years old and end up in the hospital. Kentucky is still continuing to increase its numbers. We have over 2,000 cases. We have had 25,000 people tested with 104 deaths. And we declared a state of emergency on March 6th. In terms of looking at modeling for when we're going to have a peak of cases, it really depends on which model you look at. And the modeling has changed over time. Now, the models can be affected by our social distancing, public policies that we put into place, and there's probably factors that we don't understand, but at least we're attempting, based on different models, to assess whether or not we have capacity in our hospital system, how to direct our resources. This is one projected curve based on the University of Washington's IHME model from the 10th of April, showing that potentially by April 24th or so, we should have a peak in cases. If you look at the different colors, the total bed capacity in Kentucky is over 6,000 beds, and the purple curve in terms of the number of cases doesn't reach that. This is all good messaging. If you talk about the amount of ICU beds, that's the green line, the solid green line. In terms of projected ICU beds needed based on the current data, we still should have enough ventilators, and we still should have enough ICU beds. Here's a projected daily death, still projecting that usually the deaths come after a couple of weeks of your cases. So the deaths are more peaking toward beginning of May. The total projected curve for deaths in Kentucky is about 994 by August 2020. These are just models. Models can be wrong, especially if you have something changing, an unexpected number of outbreaks in nursing homes and lack of resources, things can change. So we know this is a fairly infectious virus, pretty contagious, not as contagious as measles, but plenty contagious and probably twice as contagious as the flu. Let's switch gears now to talk about anatomy. This is the anatomy of the virus itself. And to give you a little clue, this is to enter into, when we talk about anatomy, we're looking at next couple of slides on serology. So we look at developing tests based on the anatomy of the virus. The anatomy looking at the S protein, which is what you use to bind to the ACE2 receptor, and other parts of that virus. If you look on the right-hand side, just to show you some similarities, this is an RNA virus, and this is actually the old SARS-CoV-2, which has got about 70-some-odd% homology with the current SARS virus. This is an RNA virus that has different components, the spike protein that stands for the S, the nucleocapsid, and most of the two main components that they're looking at so far for serologic development is the spike protein, which is probably a little more conserved than the nucleocapsid protein. But if you look at these representations, they have a lot of similarities. And so you can see that an antibody that reacts to a part of that virus can have some cross-reactivity. So the trick for developing your test is to have something that is conserved, so that won't be changing all the time, and something that does not have as much cross-reactivity with other coronaviruses. So that's their challenge, and that's what they've been doing. Serology is the blood test used to identify whether people have been exposed, which indicates the presence of having had the infection. And there are different types of serologic tests, different mechanisms. I've written some of those down, but typically the two main issues, the two main testing types that you're looking at are developing rapid diagnostic tests, which is usually just a qualitative test, or an enzyme-linked immunosorbent assay, an ELISA. and tests can have different sensitivity and specificity. It really depends on what parts of these spike proteins or nucleocapsids you're choosing, because when you look at all the countries that have been developing their tests, they're choosing different parts. They have different characteristics. CellX is that on the right-hand insert is the first rapid diagnostic test approved on April 1st with a sensitivity of 94 and a specificity of 96%. And it works just like a pregnancy test in some respects. You put a sample in the well and you have something coming up with a line. You have the C stands for control, G stands for IgG, M stands for IgM. And you can have a variety of combinations. If your control is positive, you can be both IgG and IgM positive. You can be IgG positive and IgM negative, et cetera. There's a lot of different combinations. But this is the type of testing that will help us get an idea of prevalence in the community. Now, the test itself doesn't necessarily mean we know the titer of your IgG. We don't know whether or not for sure you're protected, because that information is a little different, and there's more testing data that needs to be gathered. I'll go through some of these things, but basically there are every country has come up with their serologic tests. They're all slightly different, and their operating characteristics are slightly different. So it's not like you have one easy test that everybody does and has been able to test. That is lacking. And even in our local state, UK, for example, is trying to get their hands on some of the testing kits to try to evaluate sensitivity, specificity, operating characteristics. All that stuff is still in the process of being available. But that should be available within the next weeks to months. So if you look at Wuhan, they developed a sample. They looked at a median time to detection of IgM and IgA was about 5 days. And by the time you reached 14 days, you started to have IgG showing up. I'm going to kind of go through these quickly, but the bottom line is that within the first week, you will develop, most of the time, you will develop an IgG and IgM response. Not always 100%, and then by 2 weeks, most patients have developed an antibody response that's measurable. Whether, for example, you have all the same titers, the answer is no. Some people have a titer at 2 weeks of 1 to 1,000. Some people have a titer of 1 to 10,000. That we're still working on trying to correlate the titer also with neutralization of the virus itself. So what are we trying to do with a serologic test? If I have an IgG, I want to make sure, am I immune to that disease, at least at that moment in time? Part of the way to get at that answer is to look at a neutralization assay where you're putting that into a cell medium and measuring the cytopathic effect. And if my serum is working in terms of neutralizing that virus, then I have some measure that titer is equivalent to, at least in a cell culture assay, is effective. We don't have a lot of human data to say, if I infect you with SARS-CoV-2 and you have this titer, you don't get reinfected. So we know from previous studies with coronaviruses that your immunoglobulins do go down over time, and that whether it's SARS or MERS or regular coronaviruses, and the level of protection is something that is variable over time. So that data will continue to be collected. I'm sure they'll work on animal models also to see whether or not certain titers are more protective than others. Clinically, symptoms, what have we learned? I'm trying to distill it. Clinically, it's still a viral illness and probably a 2-week illness for most people. The first week is characterized by more mild illness. And then there's a switching point within the first week, 5 to 10 days, where you can go south and get much more severely ill, or continue to improve and eventually leave hospital. We don't know all the mechanisms or biomarkers, but we're looking carefully to try to figure out who will get sicker and who will not. And there's a lot of different ways to go about that. We have learned that there are more unusual manifestations, for example, a GI illness, more emphasized in later papers, saying that there's a substantial number of people with diarrhea. This whole loss of taste and smell as a presenting symptom, also being people more aware of that. Going into the second week, I would say that the most important thing to pay attention to is just simple things like respiratory rate, shortness of breath, hypoxia. Because if your respiratory rate starts going up above 20, 22, 24, that patient may be turning for the worst. You won't always have your laboratories back in time, but that's one clinical marker to pay attention to. And if you're looking at from a physiologic, virologic standpoint, by the time you get into your second week, a lot of your viral loads really is starting to tail down. So not all of the illness, when it comes to the severity, is related to just virus. It's also related to your body's response to that virus. And that's where we start to talk about having some of these cytokine syndromes and basically an immune system that's slightly out of control, leading to some secondary damage. So the onset of hospital admission from onset of symptoms to admission still is about 4 to 7 days. Let's go through this. This is a typical case of somebody who's fairly mild. It's about a 2-week illness. This is the first case from Washington, which we saw. Here's some chest x-rays just to remind us that the ground glass infiltrates that people talk about are seen on that CT scan, but the chest x-ray is really fairly underwhelming. If you look at cases, these are more relative cases. Remember that a lot of our patients, this is the first patient I saw was a 66-year-old who did not present with COVID, who presented with a stroke. And that story continues to be repeated, not for strokes, but for other illnesses, coming in with an MI or coming in with something else and actually having COVID. The second patient, similar type of thing, presented with loss of IV access, myelodysplastic patient who just needed a blood transfusion, lost his IV access and came in and, oh, by the way, he was a little bit short of breath and turns out to be COVID positive. Or my last patient, 69-year-old with diabetes, wasn't feeling good and really turned into the second week, turned bad quickly. I mean, was put on hydroxychloroquine, was breathing. And this is somewhat of a characteristic of some of the severe disease, that you can really turn quick. You can go from being on 2 liters to in the ICU on a vent within a couple of days. It's not the progression that we typically see with, say, predicting what a bacterial pneumonia would look like. And that's what her chest x-ray looks like. Now, she received tocilizumab and received aggressive therapy. She's now off the ventilator. So she was on the ventilator for about 8 days and then is off. So in general, in summary, you have clinical symptoms that aren't specific. We still have those labs. Everybody is looking for the golden biomarker. It's not found yet. So you can make generalizations. Severe lymphopenia, depends on what paper you read, whether it's less than 0.8, less than 0.6, elevated CRPs, elevated ferritin, elevated IL-6 related to severity and the likelihood that you'll end up on a ventilator. Most of us can't get IL-6, for example, by the time we get it back, they're on the ventilator, so it really doesn't help us. And SOFA scores. For most people, it's still a 2-week illness, although if you're sick, it really can be a long time. Switching gears, the longer we go, the more we see some issues from a clinical standpoint that are popping up. Patient that I had that looked relatively well, had a little bit of chest pain, had some shortness of breath, did have some hypoxic respiratory failure, didn't really have any underlying cardiac issues, but then into the latter part of his first week, started to get a little more short of breath, made me nervous, and started to have a little more erratic fever, and then measuring his troponins were completely normal, and they just started to climb up. Worried that he would take off and have a bad course, because again, we're all looking for what's the clue that this patient's going to turn bad. It's not easy to find out. If you look at the general data, a significant portion of patients have develop cardiac disease, cardiac injury with reduced ejection fraction and an elevated troponin. And if you take them as a group of patients, if your troponin's elevated, it is associated with increased mortality. Frequently, some of those cardiac patients do have comorbidities such as hypertension and diabetes. And one of the thoughts of the increased damage is that this is also an inflammatory disease. So potentially you're going to exacerbate underlying coronary artery disease by having this infection itself. Here's one study out of Wuhan with 138 patients with an elevated troponin, and 22% of severe cases eventually went to the ICU. They reported 2 patterns of injury at about within the first week, where your troponin just starts to go up. So it's one of the things that's mentioned in terms of monitoring patients in terms of their troponin. This isn't unusual with coronaviruses. If you looked at SARS and an outbreak in Toronto, when they did autopsies, 35% of the hearts actually had identified viral RNA SARS within the heart tissue itself. Let's turn our eyes toward severe disease. So we know that you can develop ARDS, acute cardiac injury, the ICU admission probably in 5 to 30%, depending upon which study you read. In Wuhan, looking at 52 critically ill patients, the mean age was older. They tended to be male. This holds true with a lot of studies in terms of the severe patients. Most of them had high percentage had chronic illness, fever, 62% dying by 28 days. The median duration from the onset of symptoms to the ICU was into the second week. And from the admission to the ICU to death was 7 days. Hospital-acquired infection did occur in those patients in 14%, and they did report different types of usually hospital-acquired pathogens. It can occur in any age group, though, but it does tend to increase with age and comorbidities. Seattle reported in the New England Journal of their 24 patients admitted to the ICU, again, primarily male. Symptoms began before admission and commonly just the viral symptoms. 75% required mechanical ventilation. Most of them required pressors for hypotension. I think a lot of our ICU patients end up in shock, so that it's not uncommon that they do end up on pressors. There was a 50% mortality. The median length of stay for survivors was 17 days, and in the ICU was 14 days. So clearly an illness that if you get sick, you're really going to be using a lot of resources. Reviewing this, again, 6% of critical illness, 13% severe, median time is 2 to 8 weeks in terms of symptom onset to death, and their clinical recovery, and this probably is relatively close, is long, 6 to 8 weeks. So if you're that sick. Interestingly, again, remember that this is an inflammatory disease, especially in the ICU, especially when you have stuff like ARDS. It's not uncommon in other ARDS patients that that's a pro-inflammatory disease. So the prevalence of DVT in those patients was as high as 25% in one article. ARDS is the leading cause of death in patients. The other causes include shock with possible myocarditis and cytokine storm. And the cytokine storm story is still evolving in terms of who gets sick. One of the other correlations that they mention in terms of severity of illness, especially in young people, is whether or not there's a variability in the ACE2 receptor in some patients, which leads to them having a more serious illness. That's more studies to come. Clinical monitoring really hasn't changed. We're following typical labs, IL-6 if you're hospitalized for poor outcome, and radiographic studies. You got to be careful about who actually gets tested. The calculator thing on the right didn't come out well. I tried to actually remove it. Probably didn't save it right. But they are trying to have different scoring systems, like the SOFA system, for example, in the ICU, or who will typically get more severe disease. That call scoring system, and they're different scoring systems. This, scoring system has to be relatively simple, and you have to be able to do that more at the bedside than having something that has 28 factors, which nobody's going to do. So the call system looks at comorbidities, age, lymphocyte count, and LDH, and it gives you a point system. And if you have higher point systems, you tend to get severe. It predicts that you'll get severe disease. So our testing is increasing in the hospitals. We're adding more capacity as time goes on. That's still going to be a key to dealing with this. We're changing who we're going to test. Now, this is from the 14th. We're still focusing more on hospitalized and healthcare personnel, but as our capacity increases, we will be liberalizing that some. To date, we're still quite far behind in terms of our total testing is over, still less than 2 million in terms of the number of tests that have been done. Treatment measures, I'll kind of skip that. It's still similar, shorten length of stay, shorten exposure to the healthcare worker. Supportive treatment is still the most important thing. We're using a lot of antibiotics, but probably the majority of patients are not getting secondary infections. Many people have different algorithms. This is MGH's at Harvard's algorithm for looking at ICU care, emphasizing lung protective ventilation using lower tidal volumes and using PEEP, proning patients, and then considering ECMO if needed. We got to be safe in terms of what we do for protocols for intubation of patients and for coding them. We're starting to address this in terms of our patients we're now in the middle of patients. We have patients that are looking at potentially getting tracheostomies. There's a study written up within the last week talking about comparing lessons learned in SARS and tracheostomies to what our current outbreak situation is, and people are working together to try to fashion good protocols. The focus of this for tracheostomies is to look at doing them, if you can, in the ICU setting, minimizing the number of personnel involved. But if you have to do them into the OR, to really have people that have experience dealing with this illness and not having everybody involved, trying to minimize the exposure to the healthcare person. Steroids are still not helpful unless potentially they're used in ARDS and cytokine storm. And there are no FDA-approved medications to treat, but there are many under investigation. IDSA guidelines, which is the Infectious Disease Society of America, came out on the 11th of April, and that's still a work in progress. The gist of that article was that there are no approved, there are no approved therapies, and that people should be treated in the context of a clinical trial. Now, the impact of that is still to be found. If you look at, I went today to look at Mass General, University of Washington, University of Michigan, Penn State, University of Pennsylvania, all the sites that have they have not really changed their guidelines. So there's a little bit of a disconnect between what we're doing in the front lines and what is recommended from an academic standpoint. But the point is well made, and that is we still don't have large, great data to look at in terms of how we're treating patients. We have some recommendations for desperate times, but we have to be careful about the pros and cons of what we're doing for our patients. We don't want to hurt them. We don't want to hurt other people that might be unintentionally be hurt. For example, the hydroxychloroquine supply for rheumatology patients. But we're still trying to provide the best care possible at the bedside for patients that have COVID. So that is more to come. Vaccines, there are many under development. There has been some literature, I don't know if you paid attention to it at all, but some countries have mentioned that those that have had high BCG vaccination rates may actually have a better outcome from COVID and less severe disease. WHO does not recommend BCG vaccination as a measure toward treating COVID, but that's still under investigation. That data. There might have been an unintended consequence of having a vaccination that had a potential benefit. Here's the UW algorithm, has not changed. This is as of today. It's still looking at patients and stratifying based on risk factors and sickness. And the sickness that puts you into a treatment category in general is the development of respiratory failure. So if you have acute hypoxic respiratory failure, you tend to be shunted into a treatment algorithm, either through a clinical trial or potentially through using other agents. We've been through this. There are no good data right now supporting lopinavir, ritonavir. The hydroxychloroquine data also are fairly poor. They're not really well done studies, and there are a lot of controversies about how to use that. However, there is still hope in the sense that there is in vitro data supporting the use of hydroxychloroquine. Remdesivir, also no large published data, although within the last couple of days, they published their compassionate use data showing some potential benefit of patients, and 61 patients with acute hypoxic respiratory failure receiving a 10-day course, this is their typical course, 200 milligrams loading dose, then 100 milligrams a day, that they had improved oxygenation, 57% were extubated, 47% discharged. But it's not a large clinical trial, and more data supposedly will be available within weeks about a larger randomized trial. Hydroxychloroquine is still recommended on a lot of basically most of the major sites in terms of, but with a caveat that it's not FDA approved. It's not approved for prevention. And if you're a high risk group and you have hypoxia, the recommendations are down there in terms of potential treatment. There have been premature discontinuations of an hydroxychloroquine trial in Brazil in terms of looking at the high dose, because they were using 600 milligrams a day. And they did have cardiac complications with QT prolongations and arrhythmia. So that's been completely stopped. And at one point, within the last month, there was up on the University of Michigan site that they had high dose recommendation, which has now been removed. Most of the toxicity from hydroxychloroquine is from long-term use. QT prolongation is, you need to pay attention to it. So you need a baseline EKG, you need to follow what their EKG is on that medication. Oftentimes we have patients on other medications that will prolong their QT, amiodarone, antidepressants, et cetera, et cetera. You add fluconazole, obviously trying to avoid azithromycin, although initially there was some, people were enamored with that, but the added toxicity of QT is not supporting its use. Immune modulators, the tocilizumab is still, there are clinical trials underway. We have used it in Lexington. Other places in Kentucky have used it. And it is a potentially a treatment for cytokine storm. The thought being that we are trying to get patients through an extremely critical period where they're decompensating. They're on 100% FiO2, their PEEP is 20, and they're just, unremittent fevers. They look like they're going to go down. I've used it a few times, and clinically the patients have gotten better. Whether they would have gotten better or not, I can't tell you, because it's just a critical situation. But fevers did resolve. Patients got extubated. That's all I can tell you. But an N of 2 is not a lot to go on. We have probably an N of 5 in the practice in terms of using it. And talking to other facilities that have used it, the N might go up to 20 or something. It's just not enough to make a recommendation. It is reasonable to study it, and it is reasonable to put them in a clinical trial. But if you don't have access, it's something to consider. There are some guidelines that we try to look at to document that the patient's in cytokine storm. And there are some small studies, again, 21 patients out of Wuhan that had some benefit, but it's not peer reviewed. They had multiple other medications on board, so it's difficult to figure out what the treatment effect was. Convalescent plasma, it's still an ongoing evaluation. There are, based on previous and meta-analysis, there was some benefit in treating viral infections. We have some small amount of data. There's 5 patients from China here reported where they had some type of potential benefit. There's 10 patients here that when the 10 patients, when they retested their viral loads, that they were negative. I don't know whether or not it's going to be beneficial, but we're still in the process of participating as part of the Mayo Clinic collaborative to see whether patients will benefit from that or not. But remember, at this point, we don't have any documented go-to treatments. I will skip this. Just a quick mention, not only convalescent plasma, but hyperimmune globulin and also monoclonal production of antibodies will still be a factor. And they actually may be a factor going forward if they can ramp up, because those 2 products require less volume and may be actually more effective than convalescent serum plasma therapy. We're still using public health response in the big picture. We're still identifying and isolating, working on PPE, engineering controls, administrative controls. Here's a picture of our nurses here using the latest and greatest in terms of face shields. That's a mask over an N95 to try to preserve the N95. And we have moved toward a little more mobile iPad instead of a big cart, and that's probably more acceptable to most places in terms of getting to treat your patient using telehealth and telemedicine. How do we prevent the spread? We're still isolating, we're still cohorting, following transmission-based precautions. We're masking everybody in terms of healthcare workers. And it does, there's a little table there showing you on a study that was done looking at the efficacy of surgical masks to reduce transmission based on different coronavirus, influenza, and rhinovirus. And there's some demonstrated efficacy of somebody who actually was infected. They looked at over 100 patients and they tried to measure if you put a mask or didn't put a mask on them, whether or not they were able to generate infectious particles. So the masks do tend to work. Environmental contamination is still an issue, but this is the before and after. We have to recognize again when we're working in these units that they are going to become contaminated, but cleaning works, and we got to pay attention to how we use our PPE. If we have a mask at the end of a shift, it's not unlikely to become contaminated, so be careful what you do with your hand hygiene. Not touching your mask and touching your face and before and after removing your mask, critical. How do we prevent COVID in the nursing homes? If we don't prevent COVID in the nursing homes, we won't be able to prevent COVID in the hospital. So we've got to pay attention, and that's where we have a partnership with public health, with our nursing homes, where we have to reach out, talk to them, try to help them, give them support also for what they need. From the general big picture, the federal government has recognized that as an issue. So you have public health, our congressmen, our senators, everybody trying to make sure they have adequate PPE, adequate support to make it through this as well. Because if we don't take care of one thing, it really becomes a match to light the fire still and hurt us, all of us. There is moral injury to this outbreak. I just throw this up there because we recognize that in very stressful circumstances, especially in the trenches of New York or Detroit or New Orleans, where they're struggling with some of the difficulty with resources and the workloads, that you almost have PTSD after dealing with this. We really haven't had that as much in Kentucky, fortunately to date, but expect that this could be part of the picture. And we have to be prepared, recognizing and acknowledging this can happen, supporting each other, and then we don't always have the answer. So we improvise. We have to improvise, we have to adapt, we have to overcome whatever circumstances are put before us. We're still having some issues with social distancing, so we get a D- right now. We still have to focus on that. And now let's get into the exit strategy. COVID and sentinel surveillance, this is part of what is going to be going forward. We have already sentinel surveillance for many other illnesses. So if you look at Santa Clara County, they looked at different urgent treatment centers trying to find flu cases and then switching and trying to find COVID cases. And lo and behold, they did find COVID cases in the community circulating that they would not normally have found. So this type of interaction and framework is going to be part of going forward in terms of reopening. We have different institutes, the Center for American Progress, the American Enterprise Institute, the left and the right, Harvard, different Johns Hopkins, different institutions trying to fashion plans, but they have a lot of similarities. That is increasing diagnostic testing so that we can test as many people as we need to test, which is a lot more than we have the capability of for now. Sufficient healthcare capacity to make sure we have capacity for beds, critical care, paying attention to our PPE, and then over time reopening, whether it's reopening elective surgeries on a smaller scale with probably testing all those surgical patients, making sure we have the capacity to track anybody that's positive and go backwards. We don't want to just be introducing stuff. Remember, a significant percentage of patients are asymptomatic, and we just have to pay attention to that. There's going to be a controversial issue about tracking use of embedded apps in our phones, for example, as a novel way to, if I'm turned positive, you can use that app and track Dr. Doherty, Dr. Barton, or whoever else, just anonymously saying you've been exposed to potential contact and have that as a contact trace. But that's going to require some partnership between companies, the communities, and where that goes, and the balance with civil liberties, because who controls that data? But that's something that we have to think outside the box in terms of novel ways to help maintain control of this. Gradually, we'll be lifting restrictions and opening schools, but it depends also on paying attention to our rate of infection in the community. South Korea, and there aren't any clear-cut benchmarks, but if we look at certain countries like South Korea, when they reached a certain level, like 730 cases per day or 18 new cases per million, they were able to successfully control. Right now, the US is at about 25,000 cases per day, or a lot more, 76 new cases per million. So there probably are some metrics that we can use to see whether or not it's okay to start relaxing. And as long as we have these other things in place, such as the infrastructure from a public health standpoint, the amount of testing, which includes serology and rapid testing, to deal with what we have. Then identifying persons by serology, immune persons, continuing to work on therapeutics and vaccines, and then once those are available, then all restrictions potentially can be removed. And that's all I have for today. Let me roll this over to Dr. Barton.
Thank you for joining us today, and I appreciate all the care you're providing our patients during this pandemic. About 2 weeks ago, I presented 7 guidelines for obstetrical patients on the labor and delivery unit during the COVID pandemic. Since then, I've collaborated with University of Texas, Houston, and we've come up with a manuscript that has expanded this to 18 points, and it was accepted by the American Journal of Perinatology last week and should be available online this week. So we previously discussed a couple of these points. It's important to continue to utilize scheduled cesarean deliveries or medical inductions of labor, because our goal is to have these patients admitted, deliver them, and get them out of the hospital as fast as we can. We've made the point about limiting antenatal steroids beyond 34 weeks or avoiding rescue steroids for fetal maturity enhancement, because we don't want to suppress immune response for these mothers at risk for COVID with the steroid therapy. Limiting maternal oxygen supplementation unless there's a true maternal or fetal need for that, because with these devices that are providing oxygen, we're volatilizing potential viral particles and increasing the risk for transmission. Not doing expected management of PROM after 34 weeks, and then delaying inductions if these are elective inductions, if our Bishop score is poor, until we have a better Bishop score, a lower likelihood of a prolonged induction of labor. So what I want to do is discuss some of the new additions that we've added to this manuscript. It's going to be published later this week. And one of the most common drugs we use in obstetrics is magnesium sulfate. The problem is there's a significant side effect for respiratory depression with magnesium sulfate, particularly with our higher doses. And the last thing we want in someone with a respiratory issue like COVID is respiratory depression. So the 2 main reasons we use magnesium sulfate, one is for fetal neuroprotection for infants that are going to be delivered less than 34 weeks. And there are a variety of different protocols on how to provide that magnesium sulfate. But my goal would be the lowest dose possible to get the effect that we want. And therefore, the NIH would support a single 4-gram load of magnesium sulfate over 15 minutes should provide neuroprotection for these preterm babies. The second major reason we use magnesium sulfate is anti-seizure prophylaxis in the setting of preeclampsia. Now, traditionally, we've done this for all preeclampsia, but after the task force that I was a member of in 2013, it was really decided that those without severe features really could get by without magnesium sulfate. Someone without severe features of preeclampsia has a risk of eclampsia of maybe 1 in 1,000. So I think you can make a case if you do not have severe features to withhold magnesium sulfate. But the burden becomes on the physicians and the nursing staff, because a patient may start labor without severe features, but develop that during the labor process. We have to pick this up and then initiate the magnesium sulfate as appropriate. Now, for those with severe features, clearly they need to be on magnesium sulfate. And there are a variety of different protocols, whether that's a 6-gram load, a 4-gram load. But I think the MAGPIE trial, which was published in the Lancet in 2002, one of the largest randomized studies in the history of obstetrics, over 10,000 patients, showed the benefit of a 4-gram load followed by 1 gram per hour to provide a reduction in the risk for eclampsia. And by doing this, we're using a lower dose and therefore less likely to have respiratory depression. Now, we still need to follow these patients closely if they're having symptoms, if their urine output is decreased, to try to maximize the dose that they're receiving to still get the effect. The next point is avoid aggressive fluid hydration, because aggressive hydration can worsen oxygen status. And there's no doubt that dry lungs are happier lungs, particularly when we have a pandemic of a respiratory infection. Now, typically on labor and delivery, we start with lactated Ringer's and normal saline. These are great choices in someone that comes in labor that's going to deliver in 12 to 24 hours, deliver the baby, deliver the placenta, lose 500 to 1,000 milliliters of blood. The problem is in those that are coming in, rule out preterm labor, rule out preeclampsia, that we can give a lot of salt and a lot of fluid over a short time. Now, the average American diet is 3.4 grams of salt per day. A salt-restricted diet is 2.3 grams of salt per day. But if a patient is receiving normal saline at 125 milliliters per hour for 24 hours, she gets 27 grams of salt a day. And that's way too much salt. It's markedly increasing the risk for overhydration. So we need to be very judicious in what we choose for an IV fluid and the fluid rate at which we provide. Certainly, if you're worried about blood loss, then yes, use normal saline, use a higher rate. But if it's someone that is not actively in labor, then I think using, again, choice of your fluids and choice of fluid rate can reduce the risk for fluid overload. Now, there's been a push by the American College of OB/GYN to reduce the cesarean section rate. And one of the ways that we have done this is to allow a longer second stage of labor, meaning from the time you reach complete cervical dilatation until the baby delivers. But the problem with a longer second stage of labor is you're increasing the respiratory exposures to anybody in the room during that pushing effort. So I think, and this is the point that we made in our paper, maybe it's time to back off to the original Freeman curve criteria, 1 hour for second stage in the multiparous patients, bump that to 2 hours if she has an epidural. For someone in their first pregnancy, maybe 2 hours second stage, 3 hours with an epidural. And I think you can also make a case for shortening the second stage with an operative vaginal delivery, whether that be with a vacuum or forceps, in those patients that are appropriate candidates. That we know the position, we know the station, they have adequate anesthesia, and they have informed consent for shortened second stage. We still don't know what the vertical transmission of COVID-19 is. There are a couple of case reports using serology to suggest there's a possibility, but really nothing hard and fast in the literature to support by PCR virology that there is vertical transmission. And I think until we know for sure, delayed cord clamping or cord milking should not be used to prevent potential viral transmission to the newborn. Now, I do think we have decent evidence from China that there's not COVID-19 in breast milk, so I think we can still continue to promote breastfeeding in these patients. Now, urine dipstick is classically performed on virtually every prenatal visit, but based on our publication from the Task Force on Hypertension in 2013 and the most recent update in 2019, the management of gestational hypertension and preeclampsia are now the same. So doing routine urine dipsticks for protein really doesn't make sense anymore, since it doesn't make any difference, protein or not. If you have severe manifestations, we're going to deliver you after 34 weeks. If you have no severe manifestations, we're going to deliver you at 37. So that's just one more exposure that you have to the patient for something that's really not going to change your management. But if patients have UTI symptoms if they have a new elevation in blood pressure without a previous history of hypertension, or they have well-controlled hypertension that all of a sudden has a new significant elevation, then those are patients that do warrant urine dipstick. And lastly, I make the point, a rush to judgment. Virtually every day I have a dozen new papers on the internet describing management of COVID. And I use this one paper as an example, but be careful as you read this literature. Don't just read the conclusion from the abstract. You really have to critically review these papers because many were forced into the literature without extensive review as would happen during normal times. And the classic is this hydrochloroquine paper from France that President Trump initially noted as the panacea for treatment of COVID. But when you look critically at this paper, patients who declined treatment were assigned to the control group. Well, that's not proper scientific management. Patients with the most serious relevant outcomes, ICU admission and death, were excluded from the analysis. In only one center were patients treated with hydrochloroquine, and all the other centers served as a control. And what's happened is there's been a rush to use this medication potentially for things that this paper had nothing to do with. Hydrochloroquine is not for prophylaxis. And one of the consequences, the unintended consequences here, is that patients that truly have a need for this drug, those with lupus, those with rheumatoid arthritis, there's an inadequate supply for them. So again, be very cautious in reviewing these patients. And then the other thing is the loss of common sense. There was a paper that came out saying that there's an overlap of COVID with HELP centers. HELP is an acronym for hemolysis, elevated liver enzymes, and blood platelets. And so about 10% of patients with severe preeclampsia have this. But I got a consult this week of someone at 34 weeks with a blood pressure of 180 over 110, 4+ urine protein, platelets of 32,000, AST of 70, and they're like, well, when do we wait for the COVID to get over before we deliver? This lady doesn't have COVID. She has HELP syndrome. Traditionally, she needs to receive magnesium sulfate and be delivered. So don't assume that everything that's weird is COVID. Stick with your guns on your clinical judgment. So again, this paper that we have had accepted should be published later this week in the American Journal of Perinatology. I've also submitted another paper on the management of the hypertensive patient in pregnancy in the COVID pandemic era that hopefully will also be accepted this week or the next. So I think we're going to be open to questions if we have those, and we'll all put our masks back on. Thanks.
This is Dr. Doherty again. I suppose if we're standing up here together, we should really have our masks on. We're this close. Thank you, Dr. Barton and Dr. Rodrigue, for such comprehensive, thorough updates on this extremely complicated issue. I wanted to make a couple comments before we take questions. We all know that some of the major issues here are ramping up testing. That is ramping up very, very quickly, really by the day. Another critical issue is our PPE supply. And I'd like you all to take a look at our website, lexidc.com, a video that Holly Hall, one of our hospitalists, and I made last week on PPE conservation. We don't have enough PPE. We're not going to have a Patriots airplane fly into Kentucky with 1 million N95s to resupply us. We have to conserve. We have to have fewer people walking into the room. Look at our video on telemedicine in the hospital. People should only go in the rooms if they need to deliver direct patient care, i.e. placing a dialysis catheter or the nurses directly caring for the patient. We have to do this as a PPE conservation issue. One other thing that I want to mention is that I think the first thing that we should have done as a PPE conservation issue is eliminate contact precautions for MRSA and VRE. We did that years ago here at Baptist Lexington. This is what's important, is hand hygiene. We've actually reduced the rate of MRSA and VRE by eliminating contact precautions, focusing on hand hygiene. The contact precautions for VRE and MRSA, in my opinion, are a waste of personal protective equipment, a waste of the gowns and gloves, and we are going to need those gowns and gloves. So please do that today. I've asked the people at the CDC to do that too, but so far we don't have a response on that. I think that now we'll go ahead and take some questions. Are there any, are we able to take questions? John, can you knock on the door? Hold on just a minute. We're going to try to pull these questions up. One thing I'll also mention is that we're going to continue to do these updates. I think the next one we'll plan to do in around 2 weeks. We'll announce that on emails. So we're going to continue to try to address complicated issues as they come up in real time. And it seems like some new issue comes up multiple times a day in this situation.
So could all hospitals in the Baptist system eliminate the PPE for MRSA and VRE?
Well, that's what I've suggested. So I would really like for that to happen. I think personally, it's just a waste of the gowns and gloves, and we need those for the COVID-19 patient.
There's going to be changes in recommendations over time, especially with treatment. And it's not uncommon with a new illness to have to wait for the treatments to catch up to the illness. So there's always going to be a balance between treating critically ill patients in the proper context of clinical trials and the benefit to the patient. Trying to keep a critical eye on the available scientific evidence and expanding that toward the treatment of our patients. I mean, there are many treatments that are not FDA approved in terms of everyday medicine that we use, whether it's infectious disease or other subspecialties. But it truly is a complicated calculus to figure out what the appropriate measures are. Those IDSA guidelines came out on the 11th, and they'll probably be updated in the week. They're trying to strike a balance with what is, on one hand, saying everybody needs to only be treated in a clinical trial, which does not really match what the majority of patients are being. They're not being treated in that setting. Most people do not have the capability. Most settings do not have the capability in terms of the research personnel to fill out forms and do all that kind of stuff. So it'd be nice to have that because I'd like to have more data. I'd like to see better studies, but it is balancing those two things. And you'd hope that the experts at the national level can really try to help us balance that equation.
Yeah, I think we'll go ahead and call it quits here. It's been almost an hour and a half. Thank you all for bearing with us. As I said before, we're going to try to do this again in 2 weeks. Everyone stay safe and be strong. Bye. Bye.